and welcome to the non-clinical portion of the review. Now, this is the dreaded section that many reviewers come to me about, but I'm hoping to break this down for you guys and make this a little bit easier and not so scary, so to speak. And to answer the questions up front, yes, there are non-clinical questions on the ANCC and the AANP. The AANP doesn't have as many non-clinical questions, but they are on the exam. So let's get started. Bear with me because it's going to be a good bit of reading. I stress to you guys when you're doing this, write these down, make your study boards where I say, on the front, put your terms, saying like what is the Buddhist culture, what is the culture for the Buddhist, Asian, Hispanic, healer, etc. And then on the back, have your answers posted on your bathroom door. Every time you go to the bathroom, you should be able to answer those. And I say this because the non-clinical portion is terminology. You need to know the terms. There's no way around it. Know these terms because these are definitions, and it's just that you have to have an understanding of this material. So take the time out. If you do a few a day or however you want to go about it, but you need to know the terminology and know them well. So I'm going to go through everything. I'll try to find ways to make it a little bit easier for you to retain. Some of these are just going to be definitions because it is what it is. So here we go. And I truly find that the issue with this is we just don't know what to review for the non-clinical portion. So that's what I hope that this helps you with, as well as that you know what exactly non-clinical content is and what does that mean in regards to us as nurse practitioners. So starting from the culture section, we have Buddhists. Buddhists believe in meditation. The Buddhist population practice meditation, physical and mental health, relaxation and happiness. They believe in prayer, chanting, and vegetarianism. I just think of the Buddha image that you see in different restaurants, nail salons, and they're sitting Indian style with their legs crossed. Meditating is what I think of. So Buddhists, they believe in meditation. Asians believe in acupuncture and cupping for energy and balance. I think A for Asian, A for acupuncture. Hispanics, their family holds high importance. They believe in hex and use of rituals to break particular hexes. Healers they usually self-treat. They listen for common information on how they can treat their illness. The exercise is major to the Islamic population. They believe that females should remain covered. They hold strong religious beliefs as they follow the teachings of the Quran, which is their Bible. Terms to know. If you see in my section terms to know, make sure that you know those. The terms to know. Cultural awareness. Cultural awareness is the foundation of communication, and it involves the ability of standing back from ourselves and becoming aware of our cultural values, beliefs, and perceptions. So cultural awareness is being aware of your culture and the culture of others, and not just going off of your particular biases, but that's what it means by stepping back from your own self and looking and being aware of different cultural practices. Cultural beliefs, religion, culture, beliefs, and ethnic customs can influence how patients understand health concepts, how they take care of their health, etc. And different cultures have different practices. They believe in different things, and that is how you're going to live your life and care for yourself. So we need to understand what the actual cultural beliefs are for patients so that we can understand and to work to advocate and help them based on their belief. Cultural competence, the ability of providers and organizations to effectively deliver healthcare services that meet the social, cultural, and linguistic needs of patients. So being competent enough to understand the different cultures and understanding what we need to do to serve them. And you'll see a question there that you can answer. Religious beliefs, Jehovah's Witness, they don't accept any blood products. Christians believe in prayer and spiritual healing. And the Jewish females believe in a cleanse after the menstrual cycle, and they do not work on the Sabbath. Moving on to the ethics and legal portion of this section. These are terms that we definitely need to know. Beneficence is to do good for someone. So beneficence, think benefit. You're trying to do good. You're trying to benefit them. Non-maleficence or non-maleficence, however you say it. Non-maleficence is to do no harm, no malice. We're not trying to do anything malicious, so to do no harm. Justice is simply fair. Justice has been served. You're treated fairly. Confidentiality, we know that confidentiality is the ethical principle or legal right that a physician or health professional will keep information private, so privacy. Dignity, to treat with someone with respect. Autonomy, independence, free will of an individual, as we are autonomous in our profession. Accountability, being held responsible for your actions. Veracity is truth. And malpractice is illegal or negligence provided by a healthcare provider. Now, if you look, you'll see the Nursing Code of Ethics. There are 9 of them. This is a lot to remember. Don't remember those. I want you to be familiar with them and just know that these fall in this. So if you receive a question that may ask you something to see if you are aware of the Nursing Code of Ethics, then you will know these. And I'm not going to read through all of those because if you look at them, you'll know them. But the Nursing Code of Ethics are things that we should practice and know anyway. Legal, moving on to legal, because again, backing up real quick to the Nursing Code of Ethics, if you read over those, you're going to know that there's stuff that you're going to be like, okay, duh, I know that. So just familiarize yourself with those. Legal, we have the living will. And I'm going to flip this because out of a recommendation for one of my reviewers, it may make it a little bit more easier to understand if I explain an advanced directive first, and then I'll let you know what a living will is. So looking at number 2, advanced directive. An advanced directive is a written statement of a person's wishes regarding medical treatment, often including a living will. Made to ensure those wishes are carried out should the person be unable to communicate them to a doctor. So in the case that this patient is unable to communicate for themselves, their advanced directives hold everything that they want done for them. So it can be who their healthcare power of attorney is included in the advanced directive. Their living will is included in the advanced directive, etc. Now, a living will is a written statement detailing a person's desire regarding their medical treatment in circumstances in which they are no longer able to express informed consent, especially an advanced directive. So what this is telling you, because people get hung up on those two, and a living will is a type of advanced directive. An advanced directive houses everything you need to, in the case that you can't speak on your own behalf, where a living will is one of those things included in the advanced directive to specify what you want. Durable power of attorney is a legal document that gives someone you choose the power to act in your place. That's also an advanced directive. Informed consent is permission granted in the knowledge of the possible consequences, typically that which is given by a patient to a doctor for treatment with full knowledge of the possible risk and benefits. So yes, when you go over informed consent, you know you must give them all of their risk, benefits, and anything that may encounter before whatever they are consenting to, and then they can sign. Then we roll over to hospice. All you need to know with hospice is that this is care provided in the home or in a hospice house for terminally ill patients. Understanding the difference between palliative care and hospice. Palliative care is like that transitional phase before you get into hospice. Requirements under Medicare that the patient must be deemed terminally ill by a provider in the next 6 months. So the only way that a patient can qualify for hospice is if you have deemed that they are terminally ill within the next 6 months. If it's something longer than that, then they're not on hospice. That's going to be more so that you feel that they may need palliative care and eventually they may progress to hospice. All right, moving on to HIPAA, CMS, and billing. HIPAA is the acronym for the Health Insurance Portability and Accountability Act, and this was passed by Congress in 1996. So being aware that we know what HIPAA is. HIPAA is to protect us and keep things private, but knowing that it was initiated and passed in 1996. Terms to know. Again, you see that in this section, and I tell you when you see terms to know, make sure you know them. Electronic medical record. This is simply the electronic version of the paper chart of the patient's chart. This should remain confidential as the paper chart. Healthcare providers should log out of the patient identifying screens when away from the computer. So just as we did back in the day with paper charts, This is what the electronic medical record is. So if you're in the hospital or if you're coming into a doctor's visit, this is your current chart for this event. So we keep those put away. We don't allow, just like you wouldn't leave a chart open and out for things. This is the same thing that you would do with the electronic medical record. You log out, you put your screen, you block your screen. It should not be in any way that anybody else can read or find out other medical records about this patient. Electronic health records, the way this differs, I'll tell you that. An electronic health record is the electronic version of all of the patient's health records. This is so that clinicians can seamlessly view the needed health information. So the health record houses all of your medical records. So say I am your cardiologist and your PCP has a medical record for you. I have a medical record for you. Well, within your health record, that's everything included. So I can see what the PCP has and everything that went on in that medical visit that you had, and your PCP can see everything in your cardiac visit with me. So that's what the health record is. It's everything with your health. The HITECH Act, the Health Information Technology of Economic and Clinical Health, is an act approved in 2009, so not too long ago. And this was what approved us to be able to use electronic health information technology. So this is what allowed us to be able to utilize the electronic health and the electronic medical records. Telehealth is promotion of healthcare via telecommunication. So when people are like at home, you're able to still provide care to them through telehealth, where you're monitoring their blood pressure. When they take their blood pressure, it's connected to a machine that you're able to see, and it goes to your provider. So that's a that's a example of telehealth. MPI is your National Provider Identifier. Now, this is a number used to identify healthcare providers, and it's used for billing purposes. So when you pass boards and you start working, you will apply for an MPI number, and this is your identifier, so that when they bill for certain things, they know that it is associated with you as a healthcare provider. So MPI, National Provider Identifier. And then remember, with HIPAA, we must keep all information confidential. We don't need consent for a consultation with other providers, but to send information or for family members to receive patient information, there must be consent obtained from the patient. Only healthcare providers that are active in the patient's care can review any medical information. So we know this, but making sure that you know that when you're receiving questions and seeing things of that nature. And then there's a question about consent there that you can answer. Billing, more terms that you need to know. Claims-based policy is an insurance policy that provides coverage when a claim is made against the policy, regardless of when the claim event took place. A claims-made policy is most likely to be purchased when there is a delay between when claims are filed and when they occur. So this is only beneficial if a claim is made while your policy is active. So claims-based policy only protects you if you are covered when the claim is filed. Now, occurrence-based policy. This is a policy covering claims that arise out of damage or injury that took place during the policy period, regardless of when claims are made. So occurrence-based, you're still covered with occurrence-based. If that makes sense. And I will also, you should listen to my video in the group for claims versus occurrence, because it'll kind of help you too if you need to go more into that. But that's occurrence versus claims. And so again, to reiterate real quickly, claims are the ones that the insurance policy that is provided covers when a claim is made against the policy. So this is only beneficial if a claim is made while you're active. CPT is your current procedural terminology. So this is a medical code set that is used to report medical, surgical, and diagnostic procedures and services to entities such as physicians, health insurance companies, and accreditation organizations. So you know CPT codes, and that's what it is. ICD-10 is the International Classification of Diseases. So this is the global health information standard for mortality and morbidity statistics. These are increasingly used in clinical care and research to define diseases and study disease patterns. as well as manage healthcare and monitor outcomes and allocate resources. So that's an ICD-10 code, is where they classify certain things like CHF and things of that nature. Let's move on to CMS, which is the Center of Medicare and Medicaid Services. Medicare is the federal health insurance program for people who are 65 or older, certain younger people with disabilities, and people with end-stage renal disease. So what that means is, that like with Medicare, there's some people, the Medicare Part A, everyone receives at the age of 65. They qualify for that. If you're 65 and older, but people who are younger than 65, if you have disabilities or things such as end-stage renal disease, it qualifies you for Medicare Part A as well. Medicaid is a healthcare program that assists low-income families or individuals in paying for long-term medical and custodial care costs. Medicaid is a joint program funded primarily by the federal government and run at the state level, where coverage may vary. Now, with this, I tell you guys to think about it. Medicare allows you, provides you with coverage so that you can get care. Medicaid aids and helps the low income people. So that's how I'll tell you to think about it. So the low income population may need some aid and assistance in receiving medical services. So that's what Medicaid is. Now let's talk about Medicare and the different parts of it. Medicare Part A is the Medicare plan that you receive automatically if you are 65 years old or older, disabled, or have end-stage renal disease. So when I tell you this, I say think Part A and think automatic is A. Part B, this Medicare plan is something you would have to include. So you have to add Part B. This provides coverage for your outpatient needs like labs, surgeries, doctor visits, wheelchairs, walkers, etc. So I say the basics, the outside basics that you need. So B for basics. Part B. Part C is the choice plan, and it allows for additional services such as vision and dental. This is where the uproar comes because you're 65 and older, and majority of us need vision coverage, and we definitely need dental coverage. So why is this something that you have to get additional? But it's a choice plan. You have the choice of adding it or not. It is not included in the automatic Part A portion of Medicare. So this is something additional that you have, and you can also keep your Part A and Part B, but you have to pay additional to add the choice plan. So Part C is your choice to add that on there. And then Part D is prescription coverage. I say D for Part D, D for drugs. So those are the ways that I teach to remember the Medicare parts. Incident 2 billing. Incident 2 is services that are also relevant to services supervised by certain non-physician practitioners, such as physician assistants, nurse practitioner, clinical nurse specialists, nurse midwives, or clinical psychologists. These services are subject to the same requirements as physician supervised services. So remember that incident services are supervised by a non-physician practitioner, and they are reimbursed at 85% of the physician fee schedule. For clarity's sake, they'll refer to the physician services as inclusive of non-physician practitioners. So, okay, to kind of explain that a little bit more. When we see a patient and we see them on our own, we can bill for them on our own, but it would be billed incident 2, and you'll only be able to bill at 85%. Whereas when a physician sees the patient with you, this is not incident 2, and you're able to bill at 100% for the physician. To qualify as incident 2 services, you must be part of the patient's normal course of treatment, during which a physician personally performed an initial service and remains actively. So, and what that means is, so say we have a patient with hypertension, one of the physician's patients. He has seen them. He did the initial assessment on them. He did the initial parameters for hypertension, but then and thereafter, as the nurse practitioner, I can see them without the physician and bill incident 2 and receive 85%. Okay. Insurance, HMO and PPO, things you need to know. HMO is your health maintenance organization, and this type of plan provides coverage for providers in their network. You will need to choose a PCP from the network, and this provider will have to refer you to the areas of your need. Whereas a PPO is your preferred provider organization, and so the payment is a little bit different, but it allows you to be able to select your provider. It's exactly what it says. You get to pick your preferred provider. And it doesn't require a specific network or PCP referral for specialists because, again, you get to pick your preferred provider. Whereas an HMO is health maintenance organization, they're trying to maintain their organization. So they want you to stay within their networks. Professional topics. Professional topics are huge on boards. I cannot stress this enough. I say research is number one, and professional topics is number two. And you need to focus in on your and know your knowledge and have your information and know your terminologies and be strong in these areas for board sake. So the Board of Nursing is they protect the public's health and welfare by assuring that safe and competent nursing care is provided by licensed nurses. The Board of Nurses achieves this mission by outlining the standards for safe nursing care and issuing licenses to practice nursing. So your board of nursing is at the state level. We each have a state board of nursing. So wherever you reside, you follow the guidelines that they implement and make sure that we practice, and they provide our licensing. State Nursing Practice Act. This is laws that define responsibilities of the nurse and the scope of the practice, the range of activities and services, as well as qualification for practice. The acts are intended to protect patients from harm as a result of unsafe or incompetent practice or unqualified nurses. So the State Nursing Practice Act, this is your state that sets the scope of practice for us. So again, this is the actual act. This is the act that we follow. The State Board of Nursing basically make sure that you are following these things. Standards of practice. Standards of nursing practice are developed by the ANA, and they provide guidelines for nursing performance. They are rules or definition of what it means to provide competent care. So that this is the standard of nursing. This is your standards. What are your standards when you think of things like that in a way that you can think of it? So standards of practice. Nursing, you have to set a certain standard. This is the standard that we practice at. And so the ANA, the American Nurses Association, sets standards for us. Your state puts in scopes for your area, and the state boards make sure that you follow all of these things. Certification. Certification is what we are preparing for. That is what y'all are reviewing for, to be certified in what you're doing. So this test is defined. The ANCC is a certifying body. The AANP certifying body. So certification is a process by which a non-governmental agency validates, based upon predetermined standards, an individual's nurse's qualification for practice in a defined functional or clinical area of nursing. Now, licensure requires requirements for licensure, and it defines the scope of nursing practice. This is granted by a state government agency, which is, again, our State Board of Nursing. It is a governmental agency that allows for our licensing and our licensure, where certification is non-governmental. You get that from the ANCC and the AANP. Those are certifying bodies. Again, whereas your licensure, you get that from a governmental, state-based agency, which is your Board of Nursing. Consultation. A consultation is when two people discuss and use expert knowledge for the patient's improvement. So again, your PCP may consult me if you're having cardiac issues. They're consulting somebody for their expertise. Collaboration, the action of working with someone to produce something. So like an MD and an NP collaborate together to provide care for their patients. So for example, you get a collaborative agreement when working with an MD because y'all are collaborating over this patient population. You're working together. The health belief model. This is a psychological model that attempts to explain and predict health behaviors. So, for example, a smoker. So, if the individual's perception is that smoking can cause a serious disease and that they are susceptible, and if they believe that the likelihood of improving this action, um, then it is more likely that the smoker will attempt to quit smoking and be successful. So the health belief model is all about what you believe in and what's your perception on things. And so it's saying to you, so if I believe that smoking is actually a problem and that I believe that smoking is actually going to cause me cardiovascular risk factors and cause me these issues, then I'm more likely to stop because of my perception of what it's doing to me. That's what the health belief model means. And I wanted to throw in the family systems theory. The family systems theory, I do want y'all to kind of think on that too. The family systems theory is the theory that family, you and your family are one. So, for example, it's trying to say that the theory states that you and your family affect one another. My actions affect you. It doesn't just say if it happens to me, it's just me. No, a family is one. So if it affects you, it affects all of us. That's the family systems theory. Emancipated minors. These are minors in the military. They have to be active. Married minors, and these are people under the age of 18 years old, but they do not require an adult consent because they are considered as emancipated minors. Sensitivity. This is the ability of a test to correctly identify those with the disease. Positive, and so think plus. Sensitivity has the most T's. So I want you to think the plus sign looks like a T. Sensitivity has the most T's in it. So this is the one that is positive. So it's the ability of a test to correctly identify those who positively have the disease. So how sensitive is it? How positive? If sensitivity is high, that means that there is a pregnancy test. If your pregnancy test is highly sensitive, then you know that it's strong to give you a true result if it shows you that it is positive. Whereas specificity is the ability of the test to correctly identify those without the disease. And so it's specifying those who don't have it, the negative. Now let's move on to leadership. Leadership, again, review the collaboration and consultation definition that we talked about a few minutes ago. And then I want you to think about these two. Conflict resolution. You need to understand what negotiation is. Number one, negotiation is a process where there are two or more people who work to come to a resolution. So you're negotiating. So if you have some type of conflict, or even you can think about negotiating salary, you are negotiating so that we can come to one resolution that we agree upon. So, in any situation, or you want to change a protocol on your unit, or you want to change a policy within the physician's office, your provider office, the PCP. So what you're going to do is you're going to negotiate this, and y'all are going to work together to come to one common resolution. Mediation is where a third person is involved to assist in resolving the conflict. So, okay, now we can't resolve this between the two of us, so we need an additional person to be a mediator and help us to resolve this problem. So that is a mediator. This is mediation. I also want you to look and understand what situational leadership is. Situational leadership is adjusting your style to meet the needs of those that you are trying to influence. So if you are a leader, so the NP being the leader over a certain area, a certain population that you work, you are the leader of this practice. So if you are trying to teach them, or you're trying to implement a change within the practice, sometimes based upon the situation, you have to change the way you want, the way you look at it, to fit the needs of those that you are trying to influence, so that y'all can all meet a common ground and effectively work towards the greatest good of what you're working towards. So it's situational. And so you're leading to get the impact that you need, and to properly influence the population that you're trying to to influence. So again, situational leadership is adjusting your style to meet the needs of those you are trying to influence. Advocacy. Advocacy, of course, we know as nurses, we advocate for our patients. So as nurse practitioners, we must advocate for our patients and their families because we're working to minimize the risk for the patient and the provider. Patient-centered care is huge. So that's like the new thing that they are working around, and it's a big initiative. And patient-centered care is saying that it's centered around the patient. What works for the patient and the family, and what are your beliefs? How do you want to do this? And my role as a nurse practitioner is to advocate and to make that happen to the best of my ability for you to improve in your care. Risk management is identifying and evaluating risk for the patients, the staff, etc. So in healthcare, you need to be able to understand the risk that may, and we have to manage those to prevent risk from happening, for issues happening, I should say. Peer review, knowing what a peer review is, and that's evaluation of scientific, academic, or professional works by others in the same field. And that kind of goes more along with research, but I just wanted to throw that out there to you with some additional terms that I think you should know. Also, again, understanding what incidence and prevalence is and knowing the difference between the two. So incidence is defined as the rate of new or newly diagnosed cases of diseases. So you need to understand an incident is new. So how many incidents have occurred? This is new cases of the disease. Now, prevalence is how many currently have the disease in the population at a certain time. So how prevalent is it? So let's say diabetes, for example. How many incidents do we have of diabetes in South Carolina right now? So that's new cases in the month of February. So that's new cases of diabetes. That's how many incidents you would tell. How prevalent is it at this time in February? It's very, you'll know the prevalence. Diabetes is high, so we'll definitely say this is highly prevalent. But the prevalence is how many currently have the disease in a certain population at a certain time. And the incident are the new cases. How many new cases do you have? So make sure you know those terms. Now, going over to research. Research, again, is huge. Make sure you know your research. Research, I want you to look at the picture that's in the workbook that I have provided. This is something I just put on there. I Googled it. Again, I tell you guys, Google images to help yourself. But making sure you know the hierarchy, knowing that systemic reviews are the strongest, randomized control trials are next, cohort studies, case reports, and then finally expert opinions. So I have a question for you to kind of implement and look at and think on that level, because you may receive questions like that. So just kind of giving you an idea of how to think of those research models so that you're not just saying, oh, I know what those are, but knowing and understanding how to place those. Terms to know. Relative risk. Relative risk, this is a ratio of the probability of an event occurring in an exposed group to the probability of the event occurring in a comparison non-exposed group. So what's the relative risk? What is the risk that a person that smokes will get heart disease compared to someone who doesn't smoke? So that's the relative risk. It's a ratio of the probability of those events occurring. Qualitative risk, this is subjective data, for example, like interviews. So getting quality results of subjective data from an interview. Quantitative research is measurable. So think quantity, we can measure quantities. Experimental research is random sampling and is used to conduct the experiment. So think about it. When you experiment on something, you're just randomly trying it. You're experimenting. Quasi-experimental, this is not randomized. It's controlled, but it's not random. So it's more of a controlled experiment. Patient-centered care, we hit on that a few minutes ago. But again, patient-centered care is involving the patient and their families in all aspects of their care. The care is provided in the manner the patient's value, in the manner that the patient values and decides. Clinical decision making should be led by the patient's decisions. root cause analysis. This is an approach designed to break down and analyze the cause of an adverse event. So it's really what it says. You're trying to get to the root cause. You're trying to see the root of it. What caused this to happen? That's the only way we are able to solve issues and make changes is because we look at what the actual root cause is. And that's how you are able to affect change. So that's why we do root cause analysis. And then sentinel events. Sentinel events are an accident that results in death. Now, I also wanted to tell you guys again, we have done therapeutic communication in nursing, but making sure you familiarize yourself with therapeutic communication. Remembering that therapeutic communication is stating open-ended questions and things. When speaking to others, keeping an open body language and not such a closed body language as if you don't want to speak to them, or that, you know, what it looks like, the nonverbal conversations, because of how we present in our body, our facial expression, things of that. Making sure that we speak to people, and making sure that we're private with their information, and covering things of that nature, and just being therapeutic. And we don't reassure patients, you know that. When they're upset about something, we go through and we explain, but we never say, no, that's not a problem, no, that's nothing to worry about. We don't reassure people um in when therapeutically communicating. um and also making sure that people are making decisions and you're allowing them to make decisions on their own. If there is a family member in the room, making sure you're asking and seeing that the patient wants the family member to stay in the room, making sure that you are focusing on the patient, because sometimes you can easily start to focus on what the family member is saying. But if the patient allows that for them to be involved, then you can allow them. But again, this is the patient. You should be talking directly to the patient. Same when you have a patient that you have to get a translator for. If you have to get a translator, remember that you're not talking to the translator, you're talking to the patient, and then the translator speaks. And so just those common things that you need to remember when covering these. And also you'll see in the workbook I have more questions just to kind of help you review through this non-clinical information. And then finally, I conclude with some tips. And just as I tell you guys all the time, set you a strict study schedule. Stick with it. Make a realistic schedule based upon your lifestyle. Don't sit here and say that you're allotting all this time to study when you know realistically that's not going to happen. Everybody's lifestyle is different. Life will happen. So oftentimes I get up and I study. I did study, and I had everything laid out, and I did everything in the mornings before I went to work, before the kids got up, before I took anybody to school. Because once your day starts, your day starts. There's no telling what can come into practice, what can come into play, what happens. So just prepare yourself and allow yourself the time so that you can adequately study and pass boards. Practice your scratch sheet. I always talk about the scratch sheet with you guys. Practice it, practice it, practice it. Again, your scratch sheet is a blank sheet where you practice writing down different things per systems that you think that you need to retain to help you on boards. Because on the day of exams, you will get 2 blank boards and something to write with. So you can write those things down before you even start your exam to help you with that. Um, I learned that from another review. I know Maria Leak talks about scratch sheets, but other reviews talk about it too, and it's highly recommended. I heard about that in school as well, so I like to spread that to other people too and say, hey, try this out. It's very helpful. It helped me. Um, do not change any answers unless you are 100% sure that they are incorrect. That is something that so many people make that mistake of changing those answers, and you're changing half the time. You change it from a correct answer to an incorrect answer. And do practice questions. Don't do these predictor exams for a particular score, because that can increase anxiety. For testing, I have test anxiety, so I tell you these things to try to help you to stay focused and things. But you need to do your practice questions just to get your mind trained on how to answer questions for boards, and review those rationales. Review all the rationales. make you a notebook for those questions that you may come into with that you have gotten wrong, and go back and review those. So this concludes the non-clinical portion of the review.